I'm an allergist immunologist. I've been in practice and have run a research group for more than 40 years. I'm based in Dallas, Texas, and in private practice. We have a significant population of primary immunodeficiency patients in our practice and manage the immunoglobulin replacement therapy for about 180 immunodeficiency patients. We've been involved in the pivotal clinical trials of virtually every product available in the United States today, and have done about 150 FDA-approved studies in our research group over the past 25 or 30 years. Humans and all mammals have evolved over the eons to protect themselves against infections. We live in a sea of microbes, bacteria, virus, fungus, and in order for animals to survive and thrive, they need to have a relationship with those microbes because the microbes have only one thing in mind: they want to reproduce, and they may find a person as a good host to reproduce. So the immune system evolved to protect us from the ill effects of the microbes around us. And there are several different elements to the host defense system. One of them is just normal skin, prevents you from being invaded by microbes. But a really important part is the immune system. And the immune system is one of the only two parts of the human body that has memory. So, of course, our brain has memory, but the immune system has memory also. And when the immune system encounters a microbe, say strep, for example, or flu, they recognize that as being foreign and mount a response to that. And the core of that response is the production of proteins called antibodies. And those antibodies attach to the microbe and help the body get rid of it, help recover from infection, and help prevent being reinfected. And a key element of the immune system is this memory, because it takes several days for the immune system to recognize and respond to a new germ. But when you see it again months or years later, the immune system's memory kicks in, and in less than 48 hours, there's a vigorous response preventing reinfection by a germ that you'd seen in the past. People with primary immune deficiency often are not able to make antibodies. There are over 500 different primary immune deficiencies, but about 75% of them have in common that those people can't make antibody normally. So the cornerstone of therapy for the majority of patients with immunodeficiency is to provide them with antibodies that they can't make on their own. Another term for that is immunoglobulin. And immunoglobulins are the antibodies or blood proteins derived from normal individuals who have encountered germs in the world, and these antibodies can be provided to the people who can't make them and protect them from getting infected. Well, the classical primary immunodeficiency discovered in 1953 is a complete inability to make antibody. And people with that problem have a life expectancy into their late teens or 20s because infections do them in before they reach adulthood. If you provide them with antibodies, most of them can have a normal or near normal life expectancy because the antibodies that are administered from normal people protect them. And Grifols is one of the world's leading plasma processors. Plasma is the liquid part of blood, and that contains these protective antibodies or immunoglobulins. And Grifols has been producing immunoglobulin for the treatment of primary immunodeficiency for decades, and has two major products in the US. I should take a step back for a minute and say there are two general ways to give these antibodies. Unfortunately, they don't come in a pill or a syrup or liquid. They have to be given internally, either by IV or by a method called subcutaneous, that is, infusing the medication under the skin. And Grifols has two products, Gamunex-C, which is an IV immunoglobulin product that's been around for decades, and Xembify, which is a subcutaneous immunoglobulin product first approved in the United States in 2019. And by giving these products, it is life-changing for people with primary immunodeficiency. And Grifols has been a leader in this area, developing new methodologies for extracting immunoglobulin from blood plasma and processing it in a way to make it safe and effective for these patients. Most primary immunodeficiencies carry an enormous burden of disease. These patients get infected with pneumonia, sinusitis, bone and joint infections, bloodstream infections. Prior to diagnosis, many patients are hospitalized 3 or 4 or 5 times a year for infections, and it's common for them to need antibiotic treatment monthly or even more often than that. And often regular oral antibiotics are ineffective for them, and so they need to get intravenous antibiotics. It's a life that is dominated by infection and its treatment. And once these patients begin their treatment, the overwhelming majority of them have few infections, and the infections that they get are much more easily managed, and the hospitalization rate drops from several times a year to rare. In fact, in the past 20 years, I have not admitted an antibody deficient patient to the hospital for treatment once they started on immunoglobulin replacement ever. So these people who live in the hospital prior to diagnosis can live normal lives or very close to normal lives once they're diagnosed and treated. Truly life-changing. Well, immunoglobulin replacement therapy, which is the general term for this kind of treatment, carries with it its own burden of care. You need to get treatments on a regular basis, for most people for a lifetime. And that might mean an IV every 3 or 4 weeks, which might mean going to an infusion center, a clinic, or hospital, or subcutaneous. And Xembify is a subcutaneous product, and that also was a revolution in the care of these patients, because subcutaneous immunoglobulin is self-administered. That is, the patients themselves or their spouse or parent can administer this on their own schedule at home at a time that's convenient for them. And that allows them to carry on with work or school and the activities of family life. For patients in the United States, until this new label change for Xembify, the only approved way of getting subcutaneous immunoglobulin is to start with an IV first. And IV has its own issues. IV requires a healthcare professional to start an intravenous, and typically the IVs are given again at a hospital infusion center or sometimes a doctor's office. For me, the most significant element of this label change is that it's now approved to begin new patients, that is, patients who've never been treated before, directly with subcutaneous immunoglobulin or Xembify, without having to have an intravenous dose prior to the subcutaneous. The reason around this is that subcutaneous is slower to be absorbed into the body than intravenous. And so for the approximately 2 decades that subcutaneous has been approved in the United States, the requirement has been at minimum a loading dose of IV to kind of boost the level up so that the subcutaneous could keep the level going. But what the Grifols people did was to demonstrate that by giving several doses close together daily, several daily doses of subcutaneous, you can raise that level high enough so that our standard once a week or once every other week dose is adequate. Before this study, if you started a patient on subcutaneous without an IV loading dose, it would take almost 6 months before they would reach the desired steady state level. But with this new approach embodied in the Xembify label change, you can start a patient and know that they have an adequate level of protection within a week, and then they can continue on with their routine therapy. So this is a big deal for new patients who won't need an IV. It's particularly important for young children. Xembify is approved down to age 2, and starting an IV in a 2 or 3-year-old is traumatic for the child and the parent and difficult for the healthcare practitioner. So being able to provide an approved product without needing an IV is going to be very, very good for new pediatric patients. The impact on the practitioner is that many patients are diagnosed by allergist immunologists. Allergist immunologists are trained to recognize and diagnose primary immunodeficiency, but primary immunodeficiency is much less common than allergy, about 200 times less common than allergy. So most allergists can recognize immunodeficiency, but don't routinely treat it, don't routinely do IVs in their office. So this label change, allowing treatment of new patients without IV, will enable doctors who recognize and diagnose primary immunodeficiency to begin treatment immediately in a way that's not burdensome for their office and their practice. So I think it'll be very attractive to prescribers who recognize and diagnose these patients, to allow them to begin treatment without having to negotiate an IV treatment somewhere else. Subcutaneous immunoglobulin therapy requires very small needles through the skin, so they're a lot easier than an IV, but there still needs to be needle sticks. And there's a limit to the amount of fluid that you can put in a single site for subcutaneous infusion. So the Xembify label change, increasing the amount of increasing the permitted dose per infusion site will decrease the number of infusion sites that older children and adults will need, making it a more convenient and better tolerated therapy for them as well.